Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 430 of our pharmacotherapy series, which majors in adverse effects of chemotherapy and targeted agents. The next case reads, LJA, a 54-year-old man with stage 3 Hodgkin lymphoma, has received ABVD, that is doxorubicin dosed at 25 mg per meter squared IV days 1 and 15, bleomycin dosed at 10 units per meter squared IV on days 1 and 15, vinblastine dosed at 6 mg per meter squared IV on days 1 and 15, and dacarbazine 375 mg per meter squared IV on days 1 and 15, for 6 cycles. He presents to the clinic 6 months after his last cycle with dyspnea, a non-productive cough, and fever. Chest radiograph showed diffuse bilateral infiltrates. His respiratory rate was 36 breaths per minute, and his arterial blood gases were as follows: a pH of 7.5, a PO2 of 62 mm of mercury, a PCO2 of 28 mm of mercury, and an oxygen saturation of 92%. So my question to you is, what are the possible causes of his new pulmonary findings? LJA is at risk for several processes that could produce diffuse pulmonary infiltrates and dyspnea. He is immunosuppressed secondary to his lymphoma and the therapy. Therefore, LJA has an increased risk for infection and may have pneumonia. In addition, the infiltrates may represent a relapse of his disease. Pulmonary infiltrates also may represent toxicity from one or more of the cytotoxic agents he received. Further diagnostic workup is necessary to establish the cause. A bronchoscopy with bronchoalveolar lavage and a biopsy with pathologic and microbiologic evaluations were performed. Bacterial, fungal, and viral cultures were negative, and the biopsy revealed inflammation and fibrosis with no evidence of lymphoma. These results are highly suggestive of chemotherapy-induced pulmonary damage. So my question to you reads, which of the agents that LJA received is associated with pulmonary toxicity? LJA has received bleomycin, and that places him at risk for pulmonary toxicity. As part of initial workup before initiating chemotherapy with ABVD, LJA had pulmonary function tests, which were normal. Many chemotherapy agents have been associated with pulmonary toxicity, and the varying types of mechanisms and clinical presentations have been reviewed. Several reviews discuss the different types of pulmonary toxicities associated with anti-cancer agents. Among all chemotherapy agents, bleomycin is associated with the highest incidence of pulmonary toxicity. Although several types have been reported, the most frequent is interstitial pneumonitis followed by pulmonary fibrosis. Patients generally present with a non-productive cough and dyspnea. Clinicians may detect only fine crackling bibacillar rales that often progress to coarse rales. The chest radiograph may be normal in the early stages, but patients can exhibit bilateral alveolar and interstitial infiltrates. Arterial blood gases show hypoxia, and pulmonary function tests generally reveal a progressive fall in the diffusing capacity without a significant decrease in the forced vital capacity. The most significant factor associated with the development of pulmonary toxicity is the cumulative dose of bleomycin. At total doses less than 400 units, fewer than 10% of patients may experience pulmonary toxicity. When the cumulative dose reaches 450 to 500 units, the incidence is higher. A rarer, hypersensitivity reaction produces fever, eosinophilia, and diffuse infiltrates, and this pulmonary toxicity is not dose-related. The mortality associated with bleomycin pulmonary toxicity is about 50%. If bleomycin is discontinued while symptoms are minimal and before pulmonary function has decompensated significantly, the damage may not progress. In contrast, patients with prominent physical and radiographic findings generally die because of pulmonary complications. Other anti-cancer agents can potentially exacerbate the pulmonary toxicity associated with bleomycin. LJA's pulmonary findings are most likely suggestive of bleomycin toxicity. Unfortunately, there are no methods for reversing the pulmonary toxicity seen with bleomycin, and treatment consists of supportive measures such as oxygen and steroids. My next question to you reads: why are routine pulmonary evaluations indicated in patients such as LJA who receive bleomycin or other pulmonary toxic agents? Dose-related decreases in diffusing capacity can occur before the onset of clinical symptoms. Therefore, routine baseline and serial pulmonary function studies are recommended. Bleomycin therapy should be withheld if the diffusing capacity falls to less than 40% of the baseline value, if the forced vital capacity falls to less than 75% of the baseline value, or if patients exhibit any signs or symptoms of pulmonary damage. Some practitioners also recommend limiting the total cumulative lifetime dose to less than or equal to 450 units. Specific screening is not routinely recommended for patients receiving other pulmonary toxic agents. However, if patients exhibit any symptoms or clinical findings, therapy should be withheld until the cause can be determined. LJA received pulmonary function tests before his first cycle of ABVD. Further tests are usually not completed, unless the patient shows signs or symptoms of shortness of breath or difficulty breathing. LJA did not receive any further studies during his chemotherapy courses, because he had no pulmonary symptoms until 6 months after his 6 cycles of ABVD. My next question to you reads: how should LJA's agent-induced pulmonary toxicity be managed? If pulmonary toxicity becomes evident, all suspected agents should be discontinued and the patient should receive symptomatic support based on their physical condition. As illustrated by LJA, other treatable causes of pulmonary infiltrates, e.g., infection, also should be eliminated. Often, pulmonary toxicity is irreversible and progressive, and effective treatments are unavailable. Corticosteroids are administered, but probably are effective only in cases of hypersensitivity-associated pulmonary damage. Nevertheless, because other effective treatments are lacking, a trial of steroids generally is indicated for all patients. If steroids are discontinued, they must be tapered carefully to avoid clinical deterioration. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 431.